Thank you all so much for coming out today. I am really excited to be here to talk to you about the effects of tobacco smoke on taking. I'm going to talk a bit, well, I'll get into what the objectives are. So I'm expanding this a little bit into some third-hand smoke because I thought it would be really interesting for you as community health professionals to hear a little bit more about this and some of the work that we've been doing in this area. I wanted to say that I'm also involved with the Colorado Department of Public Health and the Environment on our Tobacco Review Committee, and so that's the group in Colorado that is in charge of allocating the funds for that came out of our Amendment 35 or our tobacco tax dollars. And so I'm familiar with the work that a lot of you are doing, and I work with the folks in our Department of Health who do the work that a lot of you do as well. I do receive funding from the Flight Attendant Medical Research Institute through a grant to the AAP Julius B. Richmond Center of Excellence. And this visiting lectureship, in fact, is supported by a grant that Dr. Brian Mee had written to the Julius B. Richmond Center of Excellence as well. So that grant is what's allowing me to be here today, and I really appreciate the invitation to come out and also the excellent work that he did in putting the grant together. And especially want to thank Megan Chan for all of the work that she has done in getting me here and keeping me on track and on target and all of that. There, okay. So just a couple of words about the Richmond Center. Julius Richmond was a Surgeon General of the United States. He was the Surgeon General who wrote the first report on the effects of secondhand tobacco smoke on non-smokers back in the 1970s. He was a really amazing guy. He was the chair of pediatrics at Harvard and Boston Children's Hospital. He was also started the Head Start program in the U.S. government, and so he's done a lot of things outside of smoking, but this was one of the major things that he worked on. After he retired as Surgeon General, he was recruited by the Flight Attendant Medical Research, the flight attendants who were filing the class action lawsuit against the tobacco companies for the exposure that they had over all of the years that nobody had believed that tobacco smoke was bad, especially not tobacco smoke at 30,000 feet in a tiny little metal tube. And so they actually recruited him to be the special expert that was advising their lawyers through the case. And about 6 months after they recruited him to be their expert, the tobacco companies settled. And the settlement is actually what has funded the Flight Attendant Medical Research Institute. So the flight attendants are still on the board of that. And thus we named our center after Dr. Richmond. The Richmond Center is dedicated to protecting children from secondhand smoke and ensuring that all clinicians ask the right questions about tobacco and secondhand smoke exposure. We are now in the second of 2 5-year grants from FAMRI to the American Academy of Pediatrics to manage the Richmond Center. We do a lot of research in the effects of secondhand smoke on kids. So speaking of Surgeon Generals, this week is the 50th anniversary of the initial Surgeon General's report. That came out in January of 1964, and it identified smoking as a cause of lung cancer in men. I know right now that seems sort of like, oh, duh, but right back then it was actually really important and groundbreaking for the government to actually come out and say smoking is bad, because the tobacco companies still had a lot of sway over government and the economics of our society. So there are a lot of things being promoted with the release of. With the 50th anniversary of the release, including tomorrow morning, there will be a release of a new Surgeon General's report that sort of summarizes what we know up till now. So the objectives for today, one is understanding the impact of secondhand tobacco smoke on children. I know you all know it's bad. I think probably get a lot of that out of here, but I'll talk about some of the specifics and maybe give you some new information, hopefully, that you can use when you're going out into the community. Learning about the risks of smoke exposure from other apartments. And I know that you all here are working on some smoke-free multi-unit housing legislation, which is absolutely wonderful. And I'll talk a little bit about the research that I've done that helps to reinforce that data. Learn about third-hand smoke and what it means for kids, and discuss ways to decrease smoke exposure in the community. So I've shown this in every single lecture since I've been here. This came on the internet about 2 years ago, so actually fairly recently. And it shocked me that in this day, it shocked me, but it didn't, that in this day and age, it is still considered acceptable to walk your kid around in a Marlboro costume, and number 2, to manufacture and market a Marlboro costume for a toddler. So you all and I still have a lot of work to do. So what are some of the effects of secondhand smoke exposure? First of all, a little bit of epidemiology, and this is national data. I'll show you a little bit of data from Hawaii, which you probably know better than I do, and you'll be like, no, that's not the data we have now. This is old, but that's all right. 18% of children ages 3 through 11 are regularly exposed to secondhand tobacco smoke in the home, and this is by parent report. So this is a parent who's actually admitting that they smoke in the home while their child is there. However, 54% of children ages 3 through 11 have detectable cotinine levels, and this is through their serum. And so what we find is that there's a big difference between the kids who we know are exposed by the parents and kids who are exposed in places where the parents aren't smoking in the home. And that represents about 19 million children ages 3 through 11 who are being exposed to tobacco smoke somewhere. Tobacco in Hawaii is much better. Here in Hawaii, you have the third lowest smoking rate in the United States. 16.8% of adults was the latest CDC data I had, but I heard it's actually down to like 14% now. Yeah. However, there remain large ethnic disparities. Smoking is much higher, much more common among the Native Hawaiian and Pacific Islander populations and among the Hispanics, and lower among those of white or Asian descent. You also have very low rates of youth smoking and low rates of youth smoking initiation, and we know that the lower your youth smoking is, the lower your adult smoking is going to be, because most smokers start before they are at the age of 21. Some of the reasons, which you're probably all very familiar with, are your high tobacco taxes. It's fourth highest in the nation at $3.20 per pack. Colorado is actually very interesting because we had one of the highest in the nations when we passed our tobacco tax bill, but we can only pass taxes by a popular referendum now. So if we want to increase our tobacco taxes, and they are actually a dollar amount, I think it's like $1.80 per pack or something like that, which was high at the time, but has gone down proportionally as prices have gone up and other taxes have gone up. But our hands are tied. We can't increase our tobacco taxes without going back to the public again, and the public has not shown a lot of willingness to tax things except marijuana. We'll talk about that. So strong smoke-free legislation in Hawaii. You have a very strong Indoor Clean Air Act, smoke-free workplaces, and smoke-free indoor spaces. A strong media campaign to inform the public. We know that media buys are very important in getting the messages out. The CDC tips from former smokers program, they think led to about 200,000 newly quit smokers. So we know that media buys work, and you guys are putting a lot of money and effort into making sure that gets out there. You have the ability for local governments to create regulation, and I don't know how much you're familiar with what happens in other states, but in some states, the local governments are not allowed to make their own smoking regulations. So they can't. It's called preemption. The state governments can preempt a local government's efforts to strengthen anti-tobacco legislation, and often that is pressed by tobacco interests at the state level. And finally, you have licensing for tobacco retailers, and this is also important to be able to enforce the laws around sale, especially to minors. And I hope you were able to do Tobacco 21. I think that'd really be fabulous. And I think most of you are probably aware of this, but Tobacco 21 is the effort to make the tobacco purchase age 21 years of age. So just the sampling of the 4,000 plus chemicals that are in tobacco smoke, at least 250 are known to be harmful, including ammonia, acrolein, hydrogen cyanide, carbon monoxide, and sulfur dioxide. At least 69 can cause cancer: arsenic, benzene, beryllium, 1,3-butadiene, cadmium, chromium, ethylene oxide, nickel, polonium-210, which sounds like something out of a movie of some sort, vinyl chloride, and then formaldehyde, benzo, alpha-pyrene, and toluene are suspected to cause cancer, but we don't know for sure. So some of the effects that we see on children, it is a significant source of morbidity within the pediatric population. Children who are exposed to secondhand smoke have increased risk and severity of RSV bronchiolitis, 1.3 times greater odds of hospitalization, 1.6 times greater risk of otitis media, 1.8 times greater risk of asthma, 2 times the risk of developing inflammatory bowel disease, and 4.7 times the risk of developing metabolic syndrome, which is a precursor to cardiac disease in adulthood, as well as diabetes. Even very low levels of exposure have been associated with harmful effects in children. So children with even very low levels of exposure have decreased serum and antioxidant levels, decreased cognitive abilities, which is really important when you think about kids who are being exposed in multi-unit housing who are already socioeconomically disadvantaged and at a disadvantage with school attainment. And we also just have an article out that found that kids with secondhand smoke exposure have a higher risk of asthma and asthma-related visits. So we think about the life cycle of smoking, and you can see this here. It starts out in utero, where children who are exposed have lower birth weights. They're more likely to be born stillborn. They're more likely to have neurologic problems. Children exposed in infancy, along with some of the other things I talked about, are more likely to have sudden infant death syndrome. or meningitis. Children who are exposed in childhood are more likely to get asthma or have asthma exacerbation. They're more likely to have otitis media, and they're more likely to have fire-related injuries, which you don't really think about sometimes when we think about smoking, but it's a significant risk. Then in adolescence, along with the risks of asthma and other respiratory diseases and a risk of increased cancer, you have influences to start smoking. And one of the things that we're finding is that it's not only the influence of the parent and the modeling of the parent, and that kind of makes sense if you think about it, because there aren't a lot of things that kids like to imitate their parents doing, especially once they become teenagers. Usually it's littler kids who want to do that. And so why is it such a pressure for kids to start smoking when they're adolescents? And our colleague Joe DeFranza has done a little bit of work in this area. And first of all, we can see that there's nicotine priming. So when children are exposed to secondhand smoke, they're getting a pretty good dose of nicotine. And in fact, in some cases, higher than their blood levels are higher than would indicate an active smoker in adults. And it's not realistic to think that cotinine or that nicotine is not addictive, like the nicotine from a directly smoked cigarette. So we think that the brain is primed for nicotine addiction by secondhand smoke exposure, and that some children are actually addicted by that secondhand smoke exposure. And one of my colleagues tells a story about a patient of his who was a 12-year-old girl, and her mother was a heavy smoker, and the mother went on vacation, and the daughter started smoking. And she did it because she was having withdrawal symptoms. Joe DeFranza has done some work. He's had a paper that showed that there's a small subset of children who have never smoked a cigarette before that will endorse addictive symptoms. So if you do the Hooked on Nicotine checklist, they will score as addicted to nicotine before they've ever had a cigarette. And those children are almost exclusively children of people that smoke cigarettes in the home. So finally, you have the nicotine addiction that starts in adolescence, and when it starts in adolescence, persists into adulthood. Children who are adolescents can smoke 1 to 2 cigarettes per week and still endorse symptoms of addiction, but they probably don't think that they are addicted to tobacco until you really ask them the questions closely. And finally, in adulthood, we have risks of cancer, cardiovascular disease, COPD, and other diseases. Obviously, many of the diseases of adulthood are exacerbated or caused by tobacco. But, I'm a pediatrician, so I don't really think about that. There's also a social cycle of tobacco use that we start to see. In adolescence, you have some influences to start smoking, not just the family, but it's also encouraged by the media and movies. And some work that my colleague Sutansky has done have really shown that the more images that children and young adolescents are exposed to over time, the more likely they are to start smoking, the more images of tobacco. And these don't have to be just images of a bad person or a good person smoking tobacco. It can be a bad person smoking tobacco. It can be tobacco smoking with significant consequences, and it can be tobacco smoking in the context of the social of the timing of the actual movie. So like a movie that's set in the 1950s when smoking was very prevalent, that type of exposure can increase that as well. And once they start using tobacco, they may have alienation from peers who don't use tobacco. So it can be very hard for them to find a place when all of their friends are tobacco users. And in fact, we were just hearing a story earlier today about a child an adolescent who was using e-cigarettes without even nicotine in them, so that he could feel like he was part of the group by using something that appeared to be a cigarette, even though he was trying not to smoke. So if the pressure is so hard that you have to use an e-cigarette rather than quit, we have to change some of those mores. And finally, there's an economic cycle of tobacco use. A pack-a-day smoker spends over $2,000 per year. In utero, they have an increased likelihood of living in poverty, and then you have more money spent over time on tobacco. And that also can decrease the lifetime earnings, both because of the money that's spent on tobacco and because of the risk that parents will have less time to be able to go to work. They're less likely to be able to, or they're more likely to miss work because they're more likely to be sick. Their children are more likely to be sick, so they're more likely to miss work to be with their children who are sick. So it's a very sad economic cycle that happens with tobacco. So some of the other risks that we haven't talked about yet, I mentioned SIDS before. School absence is more common. Sleep problems are more common, and dental caries are more common. So it affects almost every organ system. So just talking about the very low levels in a little bit more detail, we looked at, or we meaning my colleague Kim Yulton looked at cognition in children exposed to secondhand smoke, and she found a significant inverse relationship between Coatney level and block design, reading, and math scores. And the greatest decrease was at the lowest Coatney level, so 0.1 to 1 nanogram per ml. And as I mentioned before, this provides an especially big disadvantage for poor children. So some of the prenatal and neonatal outcomes that we see, miscarriage, fetal death. It's not on here, but infertility is more common in women who smoke. Low birth weight babies, ectopic pregnancies, placenta previa and placental abruption. SIDS is more common not only in babies whose mothers smoked in postnatally, but also mothers who smoked in utero. And birth defects. You more often see cleft lip and palate, heart defects, and webbing. There's also significant risks for women who smoke. They're more likely to have reproductive health problems, the infertility that I mentioned, delaying conception delay, pregnancy complications, menstrual irregularity, and earlier menopause. And a lot of these are mediated through some anti-estrogenic effects of tobacco. And so there's some really important pathophysiologic mechanisms underlying the reasons that tobacco smoke is dangerous for women and for children. It can compromise the immune system, and your immune system is already a little bit compromised when you're pregnant, so it can make you even more likely to be sick. You respond differently to nicotine, which is interesting, and sometimes an opportunity as well. Some women really start not wanting to smoke during their pregnancy because it just doesn't feel quite as good, and so that's a great opportunity to be able to intervene with them. On the other hand, they're also more likely to start smoking back once they have the baby, and so you have to be very, very aware that that's a very vulnerable time. Women are more likely to get cancer. They're less likely to breastfeed, and we think that breastfeeding not only is very healthy for women, but also breastfeeding can help with tobacco cravings, and so you're more likely to stay quit from tobacco if you breastfeed. Osteoporosis is more common, and then very important is the risk of thrombosis or DVTs and pulmonary embolism with oral contraceptives. And really, smoking should be a contraindication to using contraception, but I think a lot of the times we think that pregnancy is probably a greater risk for those kids, for those women, so we encourage them to use it anyway. So this is a slide, a picture that was drawn for the AAP Family Art Contest. We have this art contest every couple of years, and we have people from around the world drawing pictures about what it means to them to be tobacco-free and to have a world that's free from tobacco. So going on to talk a little bit about multi-unit housing. There's been an interesting free market at work, and I think you've probably seen that here as well as in other spots. There's increasing pressure from tenants to restrict smoking in private multi-unit housing. So part of this is that most U.S. residents do not smoke, as you saw before, and especially in Hawaii, they're in the minority. People who smoke are in the minority. Most multi-unit housing residents want their buildings to be smoke-free, and we've seen this in study after study. And this actually includes a very high proportion of the smokers as well as non-smokers. And landlords see increased costs for cleaning up smoking apartments, increased fire risks, and increased complaints from tenants. So we're starting to see more and more apartment complexes going smoke-free, and municipalities that are banning smoking in their multi-unit housing. And I think it's really important as public health professionals that we support but not necessarily force those efforts, because I think the more that this can be seen as a grassroots effort, the less we have to be seen as coming in and dictating from on high. And believe me, I've been called a lot of names for some of the research that I've done, health Nazi, blah blah blah, and I think it's important that people understand that this is not a bunch of public health professionals saying this is bad. These are people who are living in these apartment complexes saying, I don't want to be exposed, this is nasty, and I have a right to live in a place where I can live smoke-free. So some of the things that are associated with these housing exposures include older apartments with thin walls, floors, and outdated ventilation systems. It can go through open windows and doorways. It drifts from decks and porches. It can come in through communal areas, and even outdoor exposures. If you're walking through a park and you get a face full of smoke, there's actually some evidence that causes a very brief reactivity in the cardiovascular system of that person. So it's not like that exposure is completely benign. The problem is that even comprehensive air sealing and ventilation improvements most often can't eliminate the transfer. So the most effective option is to ban smoking from all indoor and outdoor areas of the building. When non-smokers move into apartments previously occupied by smokers, they are exposed to tobacco residues even after 2 months of vacancy and a thorough cleaning. So it's very, very difficult to completely get tobacco smoke residue out of an apartment, and we'll talk a little bit about third-hand smoke and why that's so sticky. And a study in California concluded that having a smoking ban would save each property about $1,400 per year, which is a significant savings for most of these spots. And smoking in apartments can cause damage from fires, cigarette burns, and lingering odors. So lots of reasons to go smoke-free. Some of the benefits of banning tobacco. Parents who introduce a home smoking ban are more likely to quit smoking. So we think that if people have to have parents who have a workplace ban are also more likely to attempt to quit smoking. So we think that if we ban smoking in the places where people live, they're more likely to try and quit because it just becomes less convenient. And bans in the workplaces and public buildings have resulted in decreased rates of acute myocardial infarction, stroke, and asthma. So this can provide a very tangible public health benefit. So when thinking about this, I like to use the bacon analogy. Probably poor Brian's heard this like 80 times already. So when I talk to families about smoke exposure and smoking in the home, and I think this really works with apartment buildings as well, is when you cook bacon in your kitchen, where can you smell the bacon cooking? Everywhere. And when you're cooking bacon in one apartment, can you smell it in the other apartment? Almost always, yeah, unless it's a really, really well-sealed building. And so anywhere that you can smell bacon when it's cooking in one place, you can get tobacco smoke moving from one place to another. And so if you're smelling the cooking from the apartment next door and you're smoking in your apartment, you should let those people know that yes, you are actually, if you can smell the bacon, their bacon in your apartment, then they can smell the tobacco smoke from your apartment and they're getting exposed to it. And so that kind of helps people to understand that drift a little bit more. So public housing is a particular problem. 32% of their households in public housing include elderly residents, 35% include disabled persons, and 41% include children. And that suggests that vulnerable populations and populations that can't escape the apartment and get away if they're being exposed to tobacco smoke are especially likely to live in public multi-unit housing. A couple of studies have been done on apartments to look at quantifying the amount of exposure, amount of drift from one to the other. Tiffany Krov studied nicotine concentrations in 49 low-income multi-unit housing units in Boston, and she found detectable nicotine in 94% of the homes, including 89% of the homes where there was no smoker living. So there was clearly either residue from somebody who had lived there before or something coming from another apartment in that building. And residents of non-smoking homes who reported frequent tobacco smoke odor were exposed to higher nicotine concentrations by a urine cotinine analysis. So a few words about third-hand smoke. Third-hand smoke is the legacy of second-hand smoke. It's a contamination that remains in a room or car that persists after the smoke is gone. And I think you've all sat in a car where you're like, wow, somebody's been smoking in here, but they're already gone. But it's been there. That's what we call third-hand smoke. It contains residual pollutants that remain on surfaces and in dust, that they re-emit into the gas phase, like nicotine, or as ultrafine particles that you could inhale, or as dust, which you can also inhale. Ultrafine particles and larger dust particles both can get into the lungs, and they have different consequences for the lungs, but both can be dangerous. Some of the third-hand smoke enters textiles and creates reservoir for off-gassing over time. And this is like when you sit on a couch where somebody has smoked before, or been smoking a fair amount, and you get that off-gassing, and it sort of comes up and hits you in the face. And it can react with other compounds in the environment, such as ozone and nitrous acid, at the surfaces to yield secondary pollutants. This is a little diagram that sort of shows how that goes around the house. So you have the secondhand smoke with all those little chemical things, and it goes into the curtains. It falls onto the floor as dust. It goes into the different rooms as third-hand smoke. It gets deposited on the baby's bedding and on the floor where the baby's crawling. And we all know what babies do when they're crawling around, and they put their hands on the floor, and then they sit there and they suck on their hands. And so children are getting a pretty hefty dose of these chemicals, and we'll talk a little bit more about that in a minute. So nicotine and ozone is very irritating. Ozone is a major driver of indoor chemistry. Ozone and nicotine react with indoor material surfaces, such as wallboard and carpet, and it can yield secondary pollutants, such as volatile aldehydes with low odor or irritation thresholds of concern to human health and irritancy, formaldehyde and methylformamide. I can never even pronounce some of these things. And secondhand smoke-loaded materials can act as long-term sources of secondary pollutants. We also can get tobacco-specific nitrosamines, and these are tobacco-specific, and they are known to be carcinogenic. And you can have several hundred nanograms per square meter of nitrosamines formed on indoor surfaces in the presence of nitrous acid, which can be in the air. So you can see that we're actually creating more chemicals than you would find in secondhand smoke. So the constituents of third-hand smoke include nicotine, which is in regular cigarettes as well, 3-ethanol-pyridine, phenol, cresols, naphthalene, formaldehyde, and tobacco-specific nitrosamines, as well as ultrafine particles. And that exposure can occur via inhalation of gases and resuspended particles, through dermal absorption from contact, especially for babies who are crawling the floor, and through ingestion of the dust when they put it down and then put it in their mouths. It is present at some level wherever tobacco has been smoked, and it results in chronic low-level exposure. Increased risk of exposure to those who spend more time indoors if the space is contaminated. The children, elderly, and people with limited mobility or chronic disease. And let's go back to that slide that talked about who lives in public multi-unit housing. Exactly these three groups. So these are some pictures that really document the exposure that we see. So this shows when you have something, pictures on the wall, and you have a chronic smoker in the home, what happens when you take the pictures off and the person moves out. So you can see here that the walls are covered in this sort of brown-orange material. Right here is a vent fan where you can see it's just coated with this brown sticky stuff. A lot of this is tar from the tobacco smoke, and it's very, very sticky and adhesive. You can even see here on the air conditioner, it's stuck around the air conditioner. And this one, you can really see well how it trickles down the walls. So it ends up getting a little bit liquid when it's warm, and then it kind of seeps down the walls and just sticks there. And we had an apartment or a house once where they'd smoked in the bathroom, clearly. And we even painted it over, and still every time the bathroom got humid, those smoke streaks, those tobacco streaks would come out of the wall. And you can imagine how difficult this is to clean up. It's very sticky, and you really would have to scrape off the walls to be able to completely rid the apartment of this type of residue that's everywhere. And all of this is releasing toxic gases as you sit in that room. You can see how it collected in the grout here of this apartment, and especially over on the right on the wall next to the shower stall. And then finally here, you just see how incredibly just striking it is. All the pictures where they were is clean, and around them is just really gross. There was an interesting study done by George Matt. This goes to parents who smoke outside. And he looked at mothers who smoked, did not smoke at all, which is the initial no exposure down there. Moms who smoked and had indirect exposure, so those were moms who smoked only outside, and then moms who smoked inside the house. And you can see that the surface nicotine in the home went up between no exposure and the indirect exposure. It went up some. So even when they were going outside to smoke, they were still having a significant level of surface nicotine in the home, and then that went up very, very high to 51.33 micrograms per meters cubed for those who smoked inside the home. And you can see that you have an increase also in the infant cotinine level that corresponds to that, as well as the dust nicotine. So and the air nicotine, obviously, because that's something that would go away very quickly, is relatively low for all three groups. So even if parents are smoking outside, they're still bringing a significant amount of contamination into the home with them. And that cotinine level that you see of 2.32, where that's the cotinine level of the 6-month-olds whose mother smoked outside, that's a level that is associated, that we talked about before, that's associated with decreased cognitive function, increased asthma risk, and decreased antioxidant levels. So third-hand smoke may account for 50% of potential nicotine exposure by non-smokers. A smoking household was simulated for 28 days, 5 to 10 cigarettes per day, using a chamber finished with gypsum wallboard and carpeted with unpadded nylon. And after 10 days, the readmission from nicotine from indoor surfaces became a source of nicotine exposure similar to actually having smoking in that room. Indoor surfaces can create a reservoir that can be readmitted long after active smoking has ceased, and other tobacco constituents did not accumulate in the same manner. So it's very important to understand that this nicotine can continue to be exposed, kids can continue to be exposed to nicotine. And I think this is particularly relevant for cars. So if you smoke in a car, that car is going to have a reservoir of nicotine if you smoke it, even if you don't smoke in the car while the child is there. So how toxic is it? That's a very good question. We don't really know. The studies of contamination in real settings are largely confounded by secondhand smoke, because it's very hard to find a place that has secondhand but not thirdhand, or thirdhand but not secondhand. So we can't yet measure the independent hazard of third-hand smoke. We can't separate them from secondhand from third-hand smoke in population studies very easily either, because we can't be sure that somebody who says they're only smoking outside is only smoking outside. And we also don't know how much of your cotinine levels due to secondhand smoke versus off-gassed third-hand smoke. However, the dose does make the poison, and we think that the more that somebody is exposed to, the more significant their problems will be from it. So breathing exposure, breathing volumes are related to size, and this gets into why smoke exposure and third-hand smoke are so much worse for little kids than for big people. So it's about 10 to 12 milliliters per kilogram of body weight. So it's roughly the same between infants and adults. However, breathing rates are very different. A 1-year-old breathes about 30 times per minute. A 3-year-old breathes about 24 times a minute, and a healthy adult will breathe about 16 times a minute. Although the sick adults that are more likely to be in a home that has multi-unit housing, or the public multi-unit housing, are probably breathing a little bit faster because they probably have respiratory illnesses already. So for children, especially young children, it's about a 1.5 to 1.8 times greater exposure per kilogram to those airborne pollutants. And so that's probably part of the reason why children seem to be more affected by secondhand smoke exposure than adults. Plus, they can't escape it. So a 3-year-old who's being exposed and doesn't like it can't just leave the home, versus an adult who can say, well, I'm just going to go out for a walk, and they may not even know why. Finally, ingestion. We really don't know. We don't know the difference between the risks for tobacco smoke ingestion versus the risks for tobacco smoke inhalation, because that's really, really hard to tease apart. But we do know that dust ingestion is about 10 to 16 times higher in toddlers per kilogram. So infants eat 2 times as much dust per day. I didn't realize I ate 50 milligrams of dust per day, but apparently I do. But an infant would eat 100 milligrams of dust per day, which, it doesn't seem like a lot, but you can actually have a pretty heavy exposure to all of those toxic chemicals that we talked about when they're going through the dust in the home and there has been smoking. The average 1 to 3-year-olds who are crawling and toddling and spending a lot of time on the ground is about 10 to 14 kilograms, or 22 to 32 pounds, and the average adults are about 5 to 8 times heavier. So infants are about 10 times more vulnerable to exposures due to their systems being less able to metabolize, detoxify, and excrete pollutants. So you can see that there's a much higher risk for these exposures for infants and small children than it is for an older school-age child or an adolescent even, let alone an adult. So we do have a little bit of evidence of harm for a third-hand smoke. NNK and NNA, which is third-hand smoke-specific tobacco-specific nitrosamine, disrupt fetal rat lung maturation. Mouse skin and chick nerve cells showed damage, metabolic effects seen in fish, as well as delayed development. Most smoke extract-exposed fish embryos died off. So these are some basic science studies, obviously, that have been done on third-hand smoke. Children exposed to third-hand smoke showed more cough than those living in non-smoking homes. And NNA and NNK from third-hand smoke induced DNA changes in cultured human cells. So we're starting to work on this body of evidence, but it's pretty small so far. So in terms of some national data on incursions, nearly a third of multi-unit housing residents with non-smoking homes reported smelling tobacco smoke in their building. And half of these residents reported incursions into their own units. Building incursions were more common for those residents, and this is a study that we did, we have every year, the Richmond Center does what we call the Social Climate Survey on Tobacco Control. And so we do a nationally representative survey that's done by random digit dial, including cell phones, and we also have a web internet survey panel component. So we have 2 modes that we combine to do the final analysis. And this is the results from, I think, 2 years ago. We found that building incursions were more common for residents who have children, have less than a high school education, and receive government subsidies for their housing. And we also found that buildings with the strongest smoke-free policies were the least likely to have residents who reported smelling smoke. Now, this doesn't seem too surprising, but what we did find was that when they restricted smoking to units, there was not a strong protective effect. In fact, it looked like people who, buildings where the smoking was restricted to the units, there was a little bit more likelihood of unit incursions for the people who live to be reported, which kind of makes sense. So if you're forcing people to only smoke in their units and not in the other parts of the building, they're more likely to have smoke that goes from one unit to another. And so if you're going to have smoke-free policies, it's really important to have a complete smoke-free policy rather than just having a partial one. We also looked at biologic evidence of exposure in children. What we wanted to do was look at the NHANES data that we talked about before, where you have not only biologic samples from children, but you also have survey data. We had information on what types of houses they lived in. And we really wanted to see whether children who lived in attached or multi-unit housing had higher cotinine levels, and in fact we did find that. So we were really struck by the fact that 9 of 10 white and African American children who lived in an apartment without a smoker in the home had evidence of tobacco smoke exposure. And this was obviously much lower for children who lived in detached homes. These children had higher mean cotinine levels than children who lived in detached homes, and that relationship persisted even when controlling for socioeconomic status. So it was a significant risk for having cotinine exposure to be living in multi-unit housing, and we think that that strongly supports efforts to apply smoke-free, especially public multi-unit housing, but also smoke-free multi-unit housing rules. So what about some of the other tobacco products? So this is a really difficult topic, and I've been asked so many times in this trip about electronic cigarettes. So I'll talk about them for a couple of minutes. Electronic cigarettes are widely promoted, but they're not regulated. There's variable nicotine content. There's no disclosure on their agreements. They're not child safe. So important thing to remember when you're thinking about electronic cigarettes is the little cartridges that they come with. Some of those cartridges have enough nicotine content in one cartridge to kill a child. And so if you don't have them locked up, children could potentially drink that liquid and die because it's a very, very hefty dose. It's concentrated. Adults aren't obviously going to drink that. They're going to smoke it in little individual puffs. Right now, these are completely unregulated product. The companies can put anything into them they want to. Many of these cartridges, the liquid is made in China where there's no regulatory oversight at all. And now we have big tobacco coming in and creating products. And many of these products are sold in flavors that appeal to youth. We're starting to see in our social climate survey data that young people who are non-smokers are starting to use e-cigarettes, not as a substitute for smoking, but as a way to start using a nicotine-containing product. And those kids, the 18 to 24-year-olds who use these cigarettes in our sample, 100% of them used a flavored version. So we really think that the flavors are attracting children children and young adults to e-cigarettes and addicting them without ever having to have a cigarette. They may be a great cessation tool. And I'm perfectly willing to accept that might be the case. But I'm not willing to recommend them until we know A, that they're safe, that there's some studies done, and B, that they're regulated. That we need to know the contents of, the vapor are safe, that they're not emitting so much nicotine that it's exposing people to secondhand nicotine levels that would make them addicted or sick, and that they're marketed in a way that's appropriate for the stated goal of the companies who are marketing this, which is to give current smokers an alternative to smoking when it's not appropriate, or help them quit, which I think that's okay. But addicting new smokers, that's not okay. The other piece about electronic cigarettes is that you can vape anything in them. So you can put anything into that canister. Some people are putting in non-nicotine, just plain flavored water. God knows what's in that. God knows whether, who wants to be inhaling perfume over and over again. It sounds like what that is. People are vaping marijuana, very popular in Colorado. You actually can, you distill the oil down into hash oil. And there's been some cases where they've blown up on people, so it's kind of dangerous. But you don't actually smell any marijuana coming out of it, so it just looks like you're vaping an e-cigarette. But you could be vaping marijuana or even like methamphetamine, anything that you can burn to inhale into your lungs. You can put in this. I'm assuming e-crack will come along soon. So there are a lot of dangers to this, and the FDA at this point has put out their deeming regulation. Which means that they have made it known that they are planning to assert their authority that they were given in 2010 over electronic cigarettes and other alternative tobacco products. That is now at the Office of Management and the Budget. We are hoping that will come out of OMB fairly soon so that we can get the comment period done with, and FDA can actually start regulating these things. Dissolvable tobacco products look like candy. They are like Camel Orbits. I don't think they've been here. We were talking about this earlier. I don't think they've been marketed here, but they're tobacco that's been crushed up and rolled up and made to look like candy and flavored. And so they look like Tic Tacs, they look like breath mints or breath strips or toothpicks. And kids can get a hold of them and think that they're eating like a little piece of candy, and they're not. And they can actually get poisoned by that as well. And we're starting to see an increase in poisonings from these at poison control centers. Many of these are sold with flavors that appeal to youth. And I just gave this statistic about the 18 to not 14-year-olds, 24-year-olds. There's no clear evidence of usefulness in quitting. There's no clear evidence of reduced harm. There's no clear evidence of safety. Finally, a couple words about hookah. Is that popular here? Hookah? So we're seeing this a ton in Colorado. We see all the bad stuff. So hookah is tobacco usually tobacco, almost always tobacco, that's smoked through a water pipe. But it's usually done in a bar in a communal setting. And so you have this hookah thing. It's often flavored, so they have like cherry hookah, they have lemon hookah, cinnamon hookah. I think they had like candy cane hookah over Christmas. And you pass the little thing around and you each take a hit off of it. And what people don't understand is that's really unsanitary. I mean, this is mostly like adolescents and young adults. And this is a great way to pass like herpes and other viruses back and forth. And, so I try and remind people that you're sharing germs with people that you may not know very well. And it can actually make you sick or give you a permanent viral infection. And it does have just as much tobacco. A lot of people think it's not as bad, but that's not true. So, in summary, tobacco smoke exposure causes disease and cognitive delays, even with very low exposure. Incursions of smoke from other apartments represent a significant potential source of exposure. Smoking is now banned where most adults work and play, but not where the young children, the disabled, and the elderly spend most of their time. Residents want smoke-free housing. Smoke-free housing saves money. And previous bans on smoking, such as smoking in the workplace, have resulted in increased quit attempts and improved health. I think it's a very strong case to be made for smoke-free multi-unit housing and for especially around the protection of children. So I put some, I think you all have the handout, but I put some references here. This has a couple of the ones that I really like to use when I'm talking to people. The George Matt article at the bottom that talks about the contamination from moms who smoke outside. The third one is the rates of non-smokers' exposure to secondhand smoke. And then the fourth one and the sixth one are both the Surgeon General's report that are directly related to things that I talked about here. So a lot of good information for you as public health professionals. Another great place for information is the Richmond Center's website, a little plug. So the Richmond Center has a lot of resources, there's places that you can go to print out materials, there are posters, you can get links to our slides from our art contest and the pictures from that, so people are able to use those with appropriate acknowledgement. We also have information on funding opportunities, and some of these are like the visiting lectureship, and we also have catch grants, which are community grants that could be applicable to this group. State-specific resources that we have. In fact, we have a really cool graphic where you can go and watch things change in the states when you change things around. It's kind of fun. And then we also have links to some of the housing and urban development toolkits for community advocates and for residents who want to go smoke-free in their public housing or in their multi-unit housing buildings. We also have a provisional section on tobacco control, which is a group in the AAP that works to make our members more aware of tobacco cessation activities and tobacco control activities. Not everybody is a major tobacco control advocate. Some people just want to be able to help their patients a little bit more, and that's great. But we do have affiliate membership, so if any of you are interested in joining, we have a listserv, and we have some interesting things that go on through the year in terms of advocating with pediatricians for tobacco control. So if you go to the Richmond Center website, that will lead you to the place where you can join the provisional section on tobacco control. Wanted to give a thank you to the Richmond Center, Jonathan Klein, who is our director, and Helene, Regina, and Donna, who are the staff that really make this program work well, and acknowledge that some of the slides were used with permission from the Richmond Center's website. I want to finish with this one, which I think really encapsulates children's feelings about how it feels like to be trapped by tobacco smoke. This is from Jessica Lynn, who was our first place winner in 2009. And it's just an ashtray, and it says, "It kills us too."